Thank you for watching the World Community Magazine's Hour of Power Live on Facebook with your host Edward McQueen and April Garner Davis.
Are we live? I feel alive.
I'm glad you do. And yes, we are live.
Man. Well, good evening, everybody. Good evening. And we're so glad to be here. I can speak for April on that. We're glad to be here for that. So I'm your host, Ed McQueen. Of course, Miss April Garner Davis is also the host. And, for the past couple of weeks, we didn't touch base on a whole lot of some of the medical issues that we thought were very important, and a couple of them that we want to talk on this evening is going to hit home, I think, to the Carolinas especially, and one I was not aware of, but I'll let our guests talk a little bit more about that. But April. We're going to talk about these issues, and do you before we get with our guests, will you have anything to say about that? And you want to
say about what again?
We're going to let's fill our guests in, not a guest, but everybody on our comments protocol that we follow.
Oh, okay, yeah. I'm sorry. I'm always pushing the broadcast out, so I was in the middle of doing that. But yes. Thank you first of all to our viewing audience for being with us tonight. If you have any comments or questions for our special guest, please drop them in the chat. Even if you're on Facebook, YouTube, wherever you're watching from, and we'll be sure to pull those questions in for our special guest. Of course. This guest tonight is not a stranger. This is not his first rodeo. We know that Dr. Mack is our pretty much our resident physician and our go-to person when we need to know what we need to know about health and well-being. And it's great that Christian Newman, our health editor, is actually, kind of growing up under him and taking some good notes and get some good wisdom from Dr. Mack. So we're going to be in really good hands. And especially tonight, if you are a sleep apnea sufferer, I'll say that, and you want to hear the medical report about what's going on in that area, tune in tonight. Share this broadcast with others who may know or not know whether or not they have sleep apnea. But also, Dr. Mack is going to talk to us about some diabetes treatment updates. And so we're having a good show tonight, Brother Edward. I have my pen and paper. I'm going to take plenty of notes. Plenty.
My pen and paper right beside me. Well, a lot of this stuff is going to be new, and I cherish revelations like that. And everybody should, especially when it comes to medical.
Absolutely. Updates. Yeah. So we want to say hello, good evening to some of our special audience members who are always with us. You, Brother Edward, you know who's first in the room.
And make no mistake about that.
Brother Edward Beckman. Good evening, how are you? Hopefully everything is well in Columbia. She says, "Welcome, Dr. McIver." Yes.
April, she's a great person. I'll say that on the
air. She's sweet.
She's a great person.
Absolutely. We also like to thank Bevelyn Mitchell for being with us tonight and Shirley Wiggins. If you're watching, please drop a comment in the chat. Let us know you're here. And we'll certainly share all of the warm welcomes with Dr. McIver. So without further ado, Dr. Mack, you ready? Let's bring him on. How are you doing?
I'm doing well. How are you all?
It's great, man. Great.
Gotcha. It's been a little while since I've been on, and I know I've talked to April and Brother Edward, and I said we're going to get back on and talk about some stuff, but we're going to talk about some stuff that really we've talked about before briefly, and then we're going to talk about some stuff that we have not talked about, but that definitely needs to be talked about. So, the first thing that I want to start off by saying is thanking you all for what you continue to do to get the information out to the community and the platform that you all are doing it. It's definitely needed, not just for health and wellness, but just social, economics, the whole 9 yards. So again, thank you all for doing what you do. First thing, I want to talk a little bit about some 2025 statistics, and I want to talk about the most common causes of death in 2025. The 10 most common causes of death in 2025 were, of course, heart disease, which has always been number 1. Number 2 is cancer. Number 3 is unintentional injuries, i.e. car accidents. Number 4 is stroke. Number 5 is lung disease. Next is Alzheimer's. Next is diabetes. Next is flu and pneumonia. Number 9 is kidney disease. And number 10 are liver disease and cirrhosis. So those were the 10 most common causes of death in the United States in 2025. Now, the reason why I'm talking about 2 things particularly, because 2 things that I'm going to talk about are on this list. So without further ado, let's get started.
Absolutely.
It's hard. What'd you say?
I said absolutely.
It's hard for me to give a talk, especially in our community, and not at least say something about diabetes. I got to. It's that prevalent. We're approximately 12% of the United States, African Americans, and we make up about 15% of diabetic cases. So it's very important, okay?
Yeah.
The first thing is diabetes is the 7th leading cause of death. Diabetes costs in the United States are over $400 billion annually. 400 billion with a B. That's direct costs, i.e. medicines, hospitalizations, and it's indirect costs, lost wages at work, time off from work. So that totals around over $400 billion annually. Now I'm gonna give you some stats because you all know I'm a math guy. I'm a facts and figures and math guy. Approximately 830 million people worldwide have diabetes. 830 million.
That's
a lot.
That's a lot.
Approximately 1.5 million people are diagnosed in the United States every year with diabetes. 1.5 million. 40 million people in the US have diabetes total. That's about 15% of the population. Approximately 115 million people in the United States are pre-diabetic. They have elevated blood sugars, but they don't meet the criteria to necessarily be called diabetic. That's 115 million. And the most shocking thing is 11 million people have diabetes in the United States and don't even know it. 11 million. Now, of course, the risk factors are overweight, age over the 45 or older, family history of diabetes, and lack of regular exercise or good diet. Those are just some of the risk factors. But the most concerning thing is we're seeing a huge increase in the incidence of diabetes in youth because of a more sedentary lifestyle and more young people, playing sports less and being more overweight. So that's concerning. All these facts that I give are concerning. But 11 million people are walking around the United States, have diabetes, and don't even know it. Don't even know it. I think you're about to say something, Brother Edward.
Huh?
I think you're about to say something.
That's a lot I wanted to say, but I'll let April go ahead. Man.
So, Dr. Mack, I'm glad that you're talking about diabetes tonight because, there aren't too many people that I know who are not impacted in some way. Either, they have it as a direct impact or somebody in their family, right? Which, of course, lends to the conversation about family history. But my first question is, diabetes is a disease of the what? Because there's so many
Okay.
things out there on social
Okay.
media, and I'm sure you see it all the time. If you just whisper a word
Okay.
near your phone, something pops up, and there's always an offer to, cleanse the liver, cleanse the pancreas.
Now it's much more detail than that, but that's simply what happens. It has to do with the beta cells in the pancreas.
They're trying to control their A1C,
Right.
and so much so it's overwhelming. And
Gotcha.
so, yeah, let's talk about what the updates are as far as diabetes treatment, and maybe even lean into like how GLP-1s play a role in
Okay,
all that.
that's a great segment, April, because that's exactly where I was going next. So first, let me say this: any medicine that you, or any pill or any whatever that you can't get from a physician, that you get from a pharmacy, I would not touch.
For
I'm gonna say that, and I might make some of my friends upset who give these peptides out of their office, but they'll get over it. If it's not from a physician and you go to a pharmacy and pick that medicine up, you don't know what you're really taking. All this stuff that you see on TV, these advertisements, this stuff that you can go and get without going to a physician and without going to a pharmacy, is dangerous. You don't know where that stuff is coming from.
Well, they have a caveat at the bottom of most of these things about.
They better, or they'll be in some trouble. They're called peptides because they're called analogs of peptides because they're not the real thing. So if you don't get it from a pharmacy, the likelihood is that it's not been FDA approved or regulated.
Yeah, right.
Okay, work. That's what a GLP-1 is. And there's Wegovy, Zepbound, Saxenda, are the shots, the weekly shots, and then you've got the pills now, the Wegovy pill and the Foundayo pill. So that's some of the newest things now, is that they've got some pills that are out now that you take daily as opposed to the weekly shots. Not everybody wants to take a shot. Some people are, have an aversion to needles, so they go and look at the tablets. But basically what these GLP-1s do is they basically slow down gut motility, or in other words, they slow down digestion. They quiet food cravings, what we call the food noise. They slow that down, and they signal basically to the brain that you're full, because it's food that stays in your stomach longer. Now, one of the biggest things that in medicine we realize now is that if you're going to have surgery and you're taking any of these GLP-1s, you need to stop them about a week before the surgery. Because if you're holding on to food in your stomach and you cough, sneeze, or hiccup and aspirate, that food can get into your lungs and set up an aspiration pneumonia. So your physician should tell you to stop taking these GLP-1s at least 5 to 7 days before surgery.
Dr. McIver, does it essentially make your gut lazy? Like if it's slowing down digestion, something is like coming to a halt. Something is being reduced.
It does, that GLP hormone, and that's the reason why one of the most common side effects is constipation, because it's slowing it down, and other side effects, if you're going to have any, which could be nausea or vomiting, because you're holding on to food in your stomach longer. Right.
Okay.
All right. By that food staying in the stomach, the feedback system to the brain tells the brain that, look, we got food in here already. We don't need to eat anymore.
So let me ask you this. For those who are on GLP-1s and may have been on them for quite some time now, is it possible that a GLP-1 can stop being effective for patients?
It is possible, but when I talk to my patients about it, the first thing I look at is not the medicine stopping effectiveness, but the person getting in too many carbs. Because a lot of times as people start to lose weight or their A1C start to get better, they get a little bit lax. Yeah. And they eat a little bit more and they get a little bit more carbs in than they really should get in. Now, that's the first thing I look at. And then I look at the dosage the person's taking. And so when that happens, then I look at whether or not I've got room to go up, whether it's safe to go up. Because remember, first and foremost, this isn't a weight loss. These aren't weight loss medicines. They're diabetes medicines.
Diabetes medicine.
So you still got to make sure that you're not going up so high on the medicine that you're dropping their blood sugars too low.
Yeah.
Okay.
Now, that's one side of the story. The other side of the story is that there's some medicines like Mounjaro and Zepbound that have both GLP-1 and GIPs together. So it works on two hormones. The GIP acts to help release insulin from the pancreas. So that's why medicines like Mounjaro and Zepbound actually work on two systems in the body, as opposed to, let's say, like Wegovy or Saxenda working on one. So there's some combinations too. And I don't want to get too technical here, but GLP-1 is the main class, but there's also another class called GIP, which actually some of these medicines work on both receptors in the body.
So because we're on the subject of GLPs, what are the long-term effects in terms of, like, you know, if someone has been on the medicine for quite some time, let's say more than a year, you know, is it possible that they may experience some bad side effects in the long run, or is it fairly safe?
As it stands right now, it doesn't appear to be a problem in diabetics. Because remember, this medicine's been out in Europe for decades for diabetics. So it was just happened to be a part with weight loss in some of the studies that they saw, where they said, oh, these medicines were great for diabetes, but guess what? It also has been helping people lose weight. So that's how it got the indication, and the FDA fast-tracked it for weight loss. So the problem is, if you're taking it just for weight loss, if you don't come up with a good structured plan when you come off of this medicine, the odds are you're going to gain it back if you're just taking it just for weight loss. So what I always tell my patients is, yeah, I can give it to you for weight loss if you meet the qualifications, but if you're non-diabetic, you're not going to be on this forever. So you got to make sure that you are, you know, doing what you need to do with your diet plan, your exercise plan, in anticipation of when we take you off of this medicine.
So, Doc, what other breakthroughs are there in diabetes treatment? Because, you know, GLP-1s have been on the market for quite some time now. Is there anything new? Yeah, what's going on?
Two things have happened. One is that, well, the biggest issue is that these medicines have been super costly, okay? And they've been cost prohibitive from a lot of insurances just not paying for it. You know, offices like mine having to do a whole lot of paperwork to try to get this stuff approved. And the people that were having the biggest issues were the people that were on Medicare. And I had a lot of patients on Medicare who Medicare was not paying for it at all, any of these medicines. Well, July the 1st, they rolled out something called the Medicare GLP-1 Bridge Program. So if you've got Medicare and you meet certain criteria, you can get this medicine paid for. Mainly the Wegovy, the Zepbound, and the Foundayo, which are tablets.
So now,
typically,
what is the criteria? I mean, you don't have to
well, there's different criteria, but I'm talking specifically about this Medicare Bridge Program now, which just came out July the 1st. So either you got to have a BMI of greater than 35, that's body mass index, BMI greater than 35, or a BMI between 30 and 34 with a history of chronic kidney disease, uncontrolled high blood pressure, or heart failure. Or a BMI between 27 and 29, and you're pre-diabetic, had a previous heart attack, or have a blockage in an artery in your arms or legs. Now that's a lot, but if you can meet the criteria for that, Medicare is now paying for these medicines.
Mm-hmm.
What the companies have also done, because of these knockoff medicines that we talked about earlier, they've dropped the price down on these medicines. And some of them you can get at the lowest dose for as low as $150 a month, which is still a lot. You can get some of them the medium dose for like $150 a month, and some of them at the highest doses for $200 a month. But that beats the heck out of them being over $1,000 a month.
Right.
So that's some of the windfalls that have come in to diabetes treatment with the GLP-1s and the GIPs.
So,
Go
ahead. It's okay.
No, go ahead.
I was about to say, for our viewers, Doc, and I don't want to deviate from what we said, G stands for what, and the L stands for
what? So the GLP is a hormone in the gut, all right? And these medicines bind to those receptors to slow down food getting out of your system.
Yeah.
So that's what they are. They're basically hormones in the body. And the medicine binds to those receptors to get the desired effect that we want of slowing down the gut motility, as in the GLP-1s, or to produce more insulin, as in the GIPs, without getting too technical.
Yeah.
Okay? That's the first windfall, is the Medicare GLP Bridge program that's only for certain Medicare people. Medicare, not Medicaid. Medicare is federal, Medicaid is state. Okay?
Okay.
That's the first breakthrough. The second one now is there is an indication if you have sleep apnea and have a moderate to severe sleep apnea and being eligible to get Zepbound, which is a GLP-1. So it's a GLP-1 and a GIP action. So it's another one of those medicines. But when the commercials come on TV, it's always misleading, because the first thing they'll say is, if you have sleep apnea, go talk to your doctor about getting on Zepbound.
Yeah.
Well, they've got to have a certain severity of sleep apnea. And that kind of segues into sleep apnea that I'm going to talk about in a second. But you've got to have something called an AHI greater than 15. And that's greater than 15 episodes where you stop breathing at night during the sleep study. So it's not just mild sleep apnea. This is more to the moderate to severe sleep apnea. And if that's been documented, then you'll be able to get Zepbound.
And is it Zepbound at a lower cost or no cost?
No, it's Zepbound at a very low cost, wherever it is on your insurance, but it should be covered to a large degree.
Okay. All right.
But you got to have greater than 15 AHIs though. And that's stop breathing episodes without getting too technical.
Gotcha. So I'll say this to the viewing audience. For those of you who have a diagnosis of sleep apnea, or you're thinking about getting tested, Dr. Mack just dropped some great information for you to have that discussion with your doctor, and some terminology to ask some questions about your AHI being greater than 15. Right. So make sure you take that note. Before we get into some final things about breakthroughs in diabetes treatment, there are a couple of questions in the chat. One, thank you, Lori L. Lewis Ward, for watching tonight. We appreciate you, girl. Okay, so question. She says two questions, actually. What about childhood diabetes? And when I think you talked about type 1. That's what you mentioned. But childhood diabetes is her first question. Then she says, my daughter just found out she's pregnant and kind of concerned about being borderline diabetic. What about becoming diabetic while being pregnant? Where does that fit in?
Okay, so at one point in my life, I used to deliver babies. At one point in time, I did that. And so there's something called a glucose tolerance test. And so what they do is they give you this glucose sugary drink, and they test you at 1 hour, 2 hour, and 3 hours to see where your blood sugars are. And that's really how it's determined about gestational diabetes. The treatments have gotten so good for that now till, it's not like it was when I first started in medicine 35 years ago, where those situations with gestational diabetes were very, very dire. Not that they're not important now, but the detection, the treatment, all that stuff is much better now than it was 35 years ago. So as long as the woman is having regular follow-ups, whether they're considered high-risk pregnancy and they're in a high-risk clinic or what have you, as long as they're following up with the physician, then they should be fine and following the prescribed medical treatment.
Now, Dr. Mack, I know of a situation where a woman had gestational diabetes and had to take insulin to help control her diabetes throughout her pregnancy.
Right.
How does the insulin impact the unborn child?
It doesn't. So it's good because the better you can treat that that woman, the less likely there's side effects to the baby. Okay. One of the risk factors for diabetes in a woman is having greater than a 10-pound baby. So if you've got greater than a 10-pound baby, and this is what I used to talk to the women about a lot, 9 or 10-pound baby, your risk of having diabetes at some point in time in the future, that woman, risk is it goes way up.
Really?
So I used to talk to them heavily, intently, and intentionally about your situation and the likelihood of you developing diabetes at some point in time in your lifetime.
All right, we have another question from Verdell Beckman. What is a good diet to prevent diabetes?
Low carb, higher protein. Now, how much protein you get, that have to talk with your physician about it, because there's some people that may have some kidney issues that have to watch how much protein they're getting in. But really a limited amount of carbohydrates in your diet with regular exercise and a lot of water.
Okay, so Doc, go on. When you for some people, I just want to make things simple. When you say carbohydrates, what comes out of that umbrella?
Bread, potatoes, pasta, noodles, sodas, tea, chips, nabs, cookies, pies, cakes, ice cream, sweets, desserts.
Yeah, that's right.
Somebody told me, you mean the good stuff, Doc? I said, yeah, the good stuff.
Yes.
So those are the carbs.
I have a question, Doc, and it relates to diet. People get into counting calories, counting carbs. Is there like a particular goal or threshold where people should, if they're watching their carbs, that they should strive for? Like, for example, no more than 50 grams per day, or anything that could give them a benchmark.
That's a good question, and it depends on what you're trying to achieve. Are you trying to maintain status quo, or are you trying to lose weight? So the average person in the United States gets between 300 to 400 grams of carbs a day. That's a lot. But if I tell you a baked potato has 65 by itself, you understand how you can get to 300 or 400.
That's those French fries.
So what you want to do is you want to try to stay below 125 if you can. Now it depends on if you're trying to lose weight. If you're trying to lose weight, then you probably need to be somewhere around 70 to 75.
You might as well just go there and be a palm full of grass.
At least to start the
that's something you can eat.
At least, and the main thing with the low carb type diets, and I'm not advocating any one of them, but just the low carb diets, is you want to get in the vegetables and you want to get in the meats. Now, another trick is eating your fiber first, which will help reduce your absorption of your carbohydrates and sugars.
So give us some fiber examples if you're having a meal.
Sweet potatoes.
Okay.
That's the main thing that comes in mind right now. But any kind of fiber, fiber bread, those kind of things, you want to eat your fiber first, and that will help reduce the absorption of the carbs and sugars.
Okay.
Something, Doc, just going to digress just a little bit or get back to something. We didn't talk about side effects of these things like GLP and
he did.
We touched on it. I'll go over it again. They're mainly GI symptoms: nausea, vomiting, constipation, sometimes diarrhea. but mainly nausea, vomiting, and constipation.
Mm-hmm. Mm-hmm.
Also, you can lose a large percentage of your muscle mass with these GLP-1s if you're not getting in an adequate amount of protein.
Protein, yeah.
Okay. All right.
Yeah.
Well, yeah, we've got a lot of commenters and questions coming through, and please keep the comments and questions going. And I just want to, of course, give some shout outs here. Thank you, Vincent Myers, for joining us. We will get to your question in just a moment. Stephanie Sessions Malone is another regular. Thank you, Stephanie. We see you. Thank you for being here tonight. And Tabitha Dozier Thomason from Charleston, Chuck Tito.
Highland Avenue.
Thank you for watching. God, that makes me smile really big. So, Doc, I think that as we turn the corner and we start talking about sleep apnea, I'm sure that all the things you are asking people to be aware of or cognizant of as they're trying to get their health in order, to lose weight, to watch your carbs, to keep your diabetes in check. I'm sure that there's some correlation or some connection to sleep apnea and all of this, right?
Oh yes, definitely.
Yeah. So definitely. So Vince, we will get to your question. If you have questions, please ask. But why don't we kind of segue into that and let's talk a little bit about sleep apnea.
Okay. So sleep apnea, as we call it in medicine, OSA, obstructive sleep apnea, is the most common sleep-related breathing disorder. Hear what I'm about to say. Globally, it's estimated that 1 billion, with a B, people are affected with sleep apnea.
Wow.
1 billion. 1 billion. But 80% of the people don't know they have it.
So you call it a disorder. That disorder kind of is defined by not being able to sleep or some kind.
We're gonna get into that. We're gonna get into all of that. Okay. I'll break it down for you. But let me finish with the numbers first.
Okay.
Approximately 85 million people in the United States have sleep apnea. In the US, it's estimated that 40% of men have sleep apnea and 25% of women have sleep apnea. Out of those people, 50% of it's mild sleep apnea, 30% moderate, and 20% severe. Now, what is sleep apnea? Let's talk about that for a second. Whenever you go to sleep, the soft tissues and muscles in your throat relax. That's just normal physiology. But in sleep apnea, they relax too much, in a sense, and it blocks the airways. So they just relax, collapse, block the airways, and it causes pauses in breathing. That's what an apnea is, where you pause or stop breathing. These people are not breathing while they're asleep. It can happen throughout the night, and the most common symptom is snoring. But you don't have to always snore to have sleep apnea. It's just well over 90% of people that have sleep apnea do snore. All right? What happens when you have sleep apnea and your airways are closed? Your body's not exchanging carbon dioxide and oxygen. So your carbon dioxide is going up. Carbon dioxide is an irritant to the brain and the nervous system. So when it gets to a certain concentration in the body, the carbon dioxide, it wakes you up. And that's what that gasping is, because you're trying to blow off that extra CO2, carbon dioxide, that's built up in your body. But this is happening throughout the night. And when that happens, you're killing brain cells. The newest risk factor for Alzheimer's disease is untreated sleep apnea.
Wow.
And I've been back home practicing enough, 25 years now, that I've seen patients who I thought had sleep apnea back then now have Alzheimer's. It increases your risk of having Alzheimer's by almost 50%. That's why I'm talking. And as I said earlier, when I gave you the top 10 causes of death, Alzheimer's was number 6. That's why I gave you those 2 facts about Alzheimer's and diabetes. Diabetes is the 7th leading cause of death. Alzheimer's is the 6th. This is very important stuff, because 80% of people are walking around with sleep apnea and don't know it. Now, some of them know it, but they just don't want to go and get the sleep study done.
So when you so let's dig into the don't know it, because sometimes people wake up in the mornings, they have headaches, feeling, groggy and, tired, even though they've had maybe even 8 hours of sleep, or they think they've had 8 hours of sleep. So are those kind of signs and symptoms that would make you, I guess, say, yes, you should consider getting a sleep apnea test?
April, I swear you're reading my mind, sweetie. That's where I'm going next. So whenever I talk to patients about sleep apnea, I talk about symptoms at night, symptoms during the daytime.
That's
now symptoms at night: snoring, pauses when you sleep, constant waking up throughout the night, and choking and gasping while you are asleep. Those are some of the nighttime symptoms. Some of the daytime symptoms of sleep apnea, we're talking about undiagnosed, untreated. Excessive daytime sleepiness, waking up with dry mouth and sore throat, headaches in the morning, trouble focusing, hard times controlling the blood pressures, and loss of interest in things like pleasurable things, including loss of interest in sex. Those are some of the symptoms that we see related to sleep apnea.
Now, Doc, you're gonna have to slow your roll. How does sleep apnea impact your interest in sex?
Because you're tired all the time. The last thing you're thinking about is putting in that kind of work.
Brother,
you barely can get through your 8-hour day at work.
Right.
It has to do with the fact that your muscles aren't getting the kind of oxygen that it needs. Brother McQueen, I had to say that. Your muscles, your body, it just doesn't have the kind of oxygen that it needs. So you're fatigued all the time. You're tired all the time. Your stamina is not there. Hence, your interest is not there.
So I guess that goes to Vince's question. He's been holding on for a few minutes here. What are some of the side effects from the sleep apnea medication? So if you get that diagnosis, it's already bad that if you have sleep apnea, there's side effects, but then there's medication. Can you lead into that? Is there medication?
It's not a medicine. It's the machine or
the machine, the CPAP.
Right, and we'll get to that in a second.
Okay. Okay.
Let me tell you some of the risk factors for sleep apnea, because we need to talk about that. One is obesity. That's the strongest risk factor there is for sleep apnea, is obesity. Number 2 is age. As we get older, our incidence of sleep apnea increases. Number 3 is the anatomy of the neck. The larger the neck, the more likely you are to have sleep apnea. I.e., men who have a neck size of greater than 18, women who have a neck size of greater than 16, you got a risk factor for sleep apnea. You just don't have enough airway. The neck is so thick that it's closing off the airway. Next one would be a family history of sleep apnea. Next would be tobacco use. And the next thing would be nighttime nasal congestion. It's been an associated risk factor with sleep apnea.
So what about a person that has allergies?
That's a good question.
So again, it depends on how much nasal congestion they're having. It depends on a number of different factors, but any nasal congestion can increase your risk, whatever the cause may be. Okay.
So can we go, where are you going now before I bring up something else?
I'll go wherever you want me to go, sis.
Well, listen, Tabitha, Highland Avenue to you, Tito to me. She said, I hate this CPAP machine, but I'm going to use it to take it with me everywhere I go. Let's talk about the use of the CPAP machines. First of all, are they necessary and are they safe? Let's get into all that.
It's necessary. If you can give me 10 seconds, I left my demonstration on my table. Give me
Okay,
1
good.
second.
Okay, all right.
Give me 1 second.
All right, Brother Edward, I'll tell you, this topic is an excellent topic for one, because it impacts so many people. And again, if you aren't suffering from it directly, your husband or wife is dealing with these issues.
Yeah.
It's impacting life overall, because imagine the husband or wife, lying next to you at night, you're trying to get a good night's sleep and can't because, if they're not being treated with that CPAP machine, they're probably going through the motions of those, the sounds that they're trying to make because they're gasping for air and all of the things, right? And then the snoring and all the things that the doc was talking about. So everybody's impacted by it, regardless.
I think so.
Yeah.
So before we get into the mask, let me talk a little bit about how we diagnose it. Okay. Once you come in with those daytime and nighttime symptoms, once you looked at the risk factors, once you do some of these sleep tests like the Epworth sleepiness scale and all these kind of things, you come up with a picture based off the patient, some of the symptoms that they're having. Then you say, okay, look, I think you've got sleep apnea. Let's go ahead and look at getting you tested. So that way we can see if in fact it is sleep apnea. There's two main types of tests. The first one is called a polysomnogram or sleep study.
Right.
And there's two different types of that. There's one where you go to a sleep lab, and there's another one where you can do the sleep study at home. Now, most physicians don't like sleep studies at home. It's more convenient for the patient, but you can get more information by going to a sleep lab. The insurances are the primary driver, though, to get these sleep studies done at home because it's cheaper for them to get it done at home.
So what's in a sleep lab? What's in a sleep lab? Sorry.
We'll go through all that and I'll explain that to you. Okay. But in the home sleep study, they send you the machine, the test. You put these straps on your body to look at how many times you breathe and stop breathing. You got a device on your finger, and then it comes up with this report. The report's sent to the doctor, the sleep study is interpreted, and then you say whether you have sleep apnea or not. The sleep lab, though, is a more complete study because you've got somebody that's watching you sleep. That's their job. They're asleep. Yeah, they're trained in how to adjust these machines. And so what happens is there's two main types of sleep studies in a lab. One is a continuous study where you just wear the machine all night and they look at your numbers and they come up with an AHI score. If you do it that way, though, as opposed to the second way, which is a split night study. Split night study is where you wear the machine. If they determine you have sleep apnea, they wake you up and then they put the mask on you to adjust the settings to see. And you can get all of the information done in one night with a split study.
Okay.
So whenever I write them, I usually write for split studies. The problem with the split studies, though, is they have to have enough time to wake you up and you go back to sleep and them adjust the machine to find the right setting.
And I would imagine that's a challenge because somebody has to actually go back to sleep.
It is for some people, but now there's a setting on the CPAP machine called an auto-PAP, which I'll get to in just a second, that really just gives you a range. Okay? And I don't want to jump ahead of myself, but let's talk about it for a second. The treatments for sleep apnea. The first treatment, of course, for mild sleep apnea, where you don't really qualify for a machine because you have to have a certain number of AHIs at night to qualify for the machine. So if you don't, so you can have 1 or 2 episodes at night, but it doesn't raise to the level of you need the machine. In those patients, you talk about weight loss and that kind of thing. Because usually weight loss can help with that, right? So another thing is some of these dentists are using mouth guards to kind of put in. The patients that I see with sleep apnea, they're far advanced for, I think, a mouth guard to really help. If we've got sleep apnea, I'm telling you to get a machine. Okay? Now, Another treatment is something called a UPPP. It's called a uvulopalatopharyngoplasty. That's a mouthful. So we just say UPPP. And with that, they basically cut out all the soft tissue in the back of your throat, including the little uvula that hangs down in the back. The little thing that hangs down in the back of your throat. Cut all that out. It's almost like doing a roto-rooter.
Oh, wow.
To open up the airway canal so you can get more air in.
So was that popular?
It's done for some people that, you know, have severe sleep apnea and who just, you know, are not going to be compliant with the machine. It's called a UPPP. Also, less invasive for that is if you take out the tonsils or adenoids. For some people, that can help. And the next thing would be something called nerve stimulator. People have heard about this device called the Inspire. Well, the Inspire in medicine, devices like that are an implantable device that's put in your body that stimulates the nerve controlling your tongue to keep it open while you're asleep. So that's an implantable device that's in you, that's inside of you.
Right. Yeah.
They seem pretty extreme, Doc.
Yeah, I've not sent one patient for an Inspire. Because to me, it's a little bit, and I'm not saying there's not a place for it, but I'm more so trying to convince people to let's wear this machine, let's lose the weight, and let's do what we need to do with tried and true proven methods over decades.
Right.
Okay. Now to the devices, and that's what I keep getting a question about. There's a CPAP machine, and then on the CPAP stands for continuous pressure. So you're just getting a continuous pressure.
Right.
If your AHI and your sleep study says this person did better and all their symptoms, their snoring, their leg movement, and everything did better and went away with a pressure of 10, then you set the machine for 10. But for some people, when they first put that mask on, the pressure of 10 is too much. It's too much pressure coming into their face. So there's a setting on these CPAPs called an auto PAP, which you can set a range. Let's say if my test came back saying I needed a 10, well, I can set the CPAP auto PAP setting to 5 to 12. And the machines are smart enough to know when to give the higher amount of oxygen pressure and the lower amount. So when you first put it on, it'll stay at 5. But then as you get deeper in sleep and the machine sees you're giving less resistance, it ramps up to give you the pressure that you need. That's called an auto PAP.
Yeah.
Now, taking it a step further, there's some people that won't do well on CPAP or auto PAP, and they need something called the BiPAP, where they need so much pressure that it's given 2 different pressures at 2 different ranges.
Wow.
That's the more extreme sleep apnea, right? And then there's even another one called an ASV, which is an adaptive servo ventilator, which is basically like a ventilator that if you stop breathing, it can breathe for you. So it depends on the level of sleep apnea that these people have as to what machine or device they would need.
Does Medicare cover? I'm sorry.
Yeah, once you got the diagnosis, it'll cover. Typically, the insurance pays. So typically, it's a 13-month deal. The insurance pays 80%, and the patient pays 20%. And then usually at month 13. You own the machine.
That's great.
So Doc, okay. Does sleep positioning help the person, or can it help a person who has sleep apnea? For example, we talked about how pretty much the throat, the tongue relaxes. Right. Is it possible that and I'm going back to things that we see that are commercialized that can help people. You've already addressed the mouth guard thing, because we see that everywhere. Put this thing in your mouth, bring your tongue forward, all that. But can a person adjust their sleep positioning, maybe be more, elevated or whatever the case is to help them with this condition?
They can, and it can help some. but most folks that have sleep apnea, like I said, are going to be mild to severe. Moderate to severe, and that's not going to make that much of a difference.
Okay. All right.
Again, you get back to the size of the neck. So no matter what position you're in, the size of the neck is what it is.
Okay.
So that positioning can help some, but again, there's so many factors involved with that until you have to kind of look at each individual situation. Yeah.
And going back to Vincent Meyer's question, you said there is no actual medication for it.
There's no tablet for it. It's either one of those three things I just named: weight loss, surgery, nerve stimulator, or the CPAP machine.
Okay.
Yeah.
Okay.
So the biggest obstacle that there is to CPAP machine is the mask.
Is the what?
The mask.
Okay.
So there's different types of masks. There's a nasal pillow, and I'll demonstrate that in just a second. There is a nose mask. There is a full face mask that goes over the bridge of the nose down here. And then they've got these hybrid masks now, which fit underneath the nose to mid-chin. So they've got so many options out now until you can find one that is appropriate for you.
Yeah.
Okay. So this is the nasal pillow. Can you see this okay?
Yes. Oh yeah.
Okay. So this is the nasal pillow. And the way it works is you take it, you put it over your head, and it fits right in your nose. Now, in these situations, you have to have your mouth closed, because if your mouth is open, the air is just going to come out of your mouth.
Right.
So this is the nasal pillow. This is how it works. This part fits into the machine. This is the nasal pillow. For some people, they love it because it's not having stuff all over their face.
Yeah.
The reason why it's important, though, the setting on the machine called the ramp, is that you want this to ramp up over time. If I tried to push a pressure of 10 through this, when you first put it on, you wouldn't be able to tolerate it. So that's why you ramp it up over time. Also, there's a setting on there that talks about humidity. And if you're drying out more, you can turn the humidity up to get more moisture through the tubing so that it doesn't dry you out as much. So this is the nasal pillow. Okay. The second one is the nasal mask. That's this one. And it goes over your head like this. You take it and you put it in right here. And it just goes over your nose.
We can see it.
Y'all able to see that okay?
Right. Yeah. I can see it.
So that was the nasal pillow. This is the nasal mask. Okay. The next one is the hybrid, which doesn't quite go fully over the bridge of your nose, but it goes right where your nose is. So it goes right in here. And it goes about midway to chin. So that's the hybrid mask. Okay. And this is a good one because it goes over your mouth, so you don't have to worry about keeping your mouth open. Or keep your mouth closed. So it goes like this. Okay. That's the hybrid. And then there is a full face mask that goes over the bridge of the nose, down here, and all the way over. I don't have one of those. But that's the full face mask. So you got four main types of masks that can be used: nasal pillow, nasal mask, full face mask, and a hybrid mask.
So Doc, your demonstration and your appliances, I call them appliances there, to me indicate that you have a significant amount of patients who with that issue.
Well, not only, for full disclosure, not only do I have a significant amount, but I was diagnosed 3 weeks ago.
Oh wow. Okay.
And so, and it was something that I kind of knew I had already, but I was kind of saying, let me lose some weight. Because normally when I lose weight, I get better. I feel better. My snoring goes away. Everything gets better. But I've been seeing so much stuff and reading so much literature, and having some patients pass away within the last year who could have been attributed to sleep apnea, but they would not wear the machine until I said, I got to go ahead and get a sleep study. So it was no surprise to me when it came back positive. Now, I'll tell you this. I've been wearing this machine for 2 weeks. I have had more energy. I've gone to Planet Fitness 10 out of the last 14 days. I hadn't been to had enough energy to go to Planet Fitness for the last 10 months.
Wow.
So my numbers for diabetes, tremendously better in the last 2 weeks. Tremendously.
All because you're getting better rest.
Better rest.
I think
my
that's
body's
the
not so stressed. I'm having the energy to exercise. It's that important. And I've known that. I knew that. But I knew that I could control mine by weight. But I had to be honest and realistic to myself in that I need to go ahead and just get this taken care of. And so that was my stimulation to go and get the sleep study done.
Vonda Cookie Vandross, thank you so much for watching from Columbia, South Carolina. She wants to know, what is the name of the one that keeps the mouth closed? The one you demonstrated that keeps the mouth. Okay, so I don't have any stock in this company, but the main leaders in CPAP and supplies and machines are called ResMed. Okay, and this one is a ResMed AirFit F40.
So Doc,
ResMed AirFit F40, and F stands for face, whereas the P stand for nasal pillows and the N stands for nose. So that's what those letters in there stand for. So if you say, look, you go to your supplier and say, I need a ResMed AirFit F40. That's this one.
Got it.
And then they have different sizes of it, small, medium, and large. So then that's when you have to go to your supplier, let them fit it on you, so that way you can see whether you need a small, medium, or large mask. Because there's a size for the headgear, and then there's a size for the mask.
Right.
So they kind of customize it for you.
Right.
Okay. All right. Brother, you trying to get a question out? What you got? What you got?
I guess I wanted to see if Medicare. I know you said Medicare. You gave the proportion of what Medicare will pay on that, but there's some of those things that Medicare are kind of stringent on, right? They will not. As long as you got
the diagnosis, you're good.
Okay.
As long as you got the diagnosis, you're good. Now, again, it depends on your specific plan as to how they cover it. Most of them are 80-20 split for 13 months. The insurance covers 80, the patient's covers 20. Now, here's the thing. You got to wear this mask at least 4 hours a night, at least 70% of the time.
For it to be effective.
No. For them to pay for it.
For them to pay for it.
If you don't
monitor that through the machine?
They've got a SIM card in these machines now.
Oh wow.
And it can go into the cloud, and the company that you get the machine from has to turn this information into your insurance and Medicare. And if you're not wearing this machine, you'll get a nice call from the supplier saying, I need to get my machine. At least 4 hours a night, at least 70% of the month.
Okay.
So it's a lot, Doc.
Well, you know what's interesting though? If it's effective with only 4 hours of use per night, it sounds like it's worth it. I guess you just have to figure out like which apparatus works best for you.
Right. And
Yeah,
that's the minimum now. You
that's the
really want to
minimum.
wear this anytime you sleep and
Mm-hmm.
while you're asleep. Because every
Mm-hmm.
time you go to sleep with sleep apnea, your oxygen levels dropping way down.
Mm-hmm.
When I went to sleep, my oxygen level got as low as 80%.
Oh my goodness.
And so that kills brain cells.
Mm-hmm.
45% higher chance of Alzheimer's. Now, let me tell you the other part why this is so important.
Oh, that's a good one.
And this is important. And this is the main reason why I wanted to come on and talk about, when you asked me to come on, I wanted to talk about this, sleep apnea. Untreated sleep apnea complications. These aren't all of them. These are just the top 5. Number 1, heart damage and heart failure. If you don't have enough oxygen when you're asleep, your heart has to work harder. And in some people, their heart is working harder when they're asleep than when they're awake, if they've got untreated sleep apnea. Hence, can lead to congestive heart failure.
Mm-hmm.
The second thing is untreated sleep apnea can lead to heart arrhythmias, some of them lethal, atrial fibrillation, where you can throw a clot and have a heart attack or a stroke in your sleep.
Mm-hmm.
That's why this is important. The third thing, sudden cardiac death. A person goes to sleep and doesn't wake up. They die in their sleep. A heart attack while they're asleep, sudden cardiac death. The fourth thing, worsening situations of your chronic conditions, i.e. hypertension and diabetes. If you don't get your sleep apnea treated, it will worsen those things.
Mm-hmm.
And the number one thing, like I said, and this is important, is Alzheimer's dementia. 45% higher risk in a person with untreated sleep apnea. What happens is their brain cells that are programmed, there's cells in the body that are programmed to die. They're going to die anyway, right? That's just normal and natural physiology. It's called apoptosis. Not getting too technical, but it's programmed cell death. They're going to die. What happens is low oxygens accelerate those cells dying, which in turn will increase memory loss, which in turn will cause oxygen levels to drop down, more accelerated brain cell aging, more accelerated memory loss, hence the increased risk of Alzheimer's by up to 45 to 50%. This is not to be played with. This is a modifiable and a preventable thing that you can do. I just said it's the 6th leading cause. Alzheimer's is the 6th leading cause of death.
Right.
So out of all the death certificates that are signed throughout the country, Alzheimer's is on there 6 most times.
So, Doc, 2 things. I want to get to a comment that's been, or an ask that's in the comments, but also, can you tell us if sleep apnea is an adults only disease?
No, it's not.
Okay.
It's diagnosed more in adults, but it's not an adults only thing.
That's a good question. That's a
very good question.
Good
question. Kids that usually have it are usually the super obese kids.
Okay.
But it's not an adults only thing.
All right. Okay, so we have JD Spain Sr. How are you doing this evening, all the way from Arlington, Virginia? Please talk about hygienic care of sleep devices.
Right.
I heard that people can get sick if they don't clean them the right way.
You can. So you need to use distilled water in your machine. That's the first thing. You need to change the water every night. There are filters in that machine that should be changed about every week or 2. There's headgear that needs to be changed anywhere between 2 to 6 months, depending on how the material is holding up.
Right.
How the silicone is holding up. So, again, some of them are all silicone. like this one. Some of them are silicone with, Velcro material. So it just kind of depends on the machine that you have and the supplies and the supplier that you have. But the most important thing out of all of that is there's also a reservoir that the water goes in. If there's any cracking in that, because it's plastic, if there's any cracking in that, you need to get that replaced. But the main thing is you need to change that water every night.
Every single night. And you shouldn't use it without water.
No, you shouldn't use it without water.
All right. L'Oreal wants to know, is it genetic? Is sleep apnea genetic?
There is a genetic component to it. But again, we don't know how much is genetic. Sometimes it could just be that, the neck is big and you're coming from a family of people with big necks. Or, so there's different anatomies that are involved in that. But it can be genetic.
So this kind of thing must be prevalent among athletes then.
Oh yeah. Lots.
Okay.
Lots.
And do you see, are there any stats that show that it impacts one demographic over another? Like, is it more prevalent in the Black community versus, any other community?
That's a good question, April. The problem is, like I said, 80% of people don't know they have it.
Don't even know they have it. That's right.
Right. So the demographic numbers would be skewed. I would say there's probably more non-white people that are diagnosed because they're getting the studies more. But the water has to be distilled.
Right. Yes. Wow. Listen, Doc, let me tell you, people are in the chat that I have never seen on this show before. Yolanda Dukes, what are you doing in the chat tonight? Sugar Hill.
It's Sugar Hill there.
Sugar, we got a lot of Sugar Hill in the chat tonight. Vonda Cook-Evandros, that's Sugar Hill, Cherry Hill. But
my cousin.
She said I'm about to start using mine, and it's amazing because I'm glad that people are being transparent about the fact that they're either using, like Tabitha and JD, or they're experiencing it because their spouses or whatever. Because we need to have this conversation, conversations like this.
Absolutely.
We're not on this island by ourselves when it comes to things like this.
My goal is to get even more information out to the community about things that we're not talking about. And that's why when Brother Edward asked me to come on, I said, I got the perfect topic.
Yes, it is.
Most people probably have not even heard about really anything anywhere close to this information. And there is a growing field of medicine called sleep medicine. So again, it's that important. And so, the reason why, as I said before, I want to bring these other facts to it too. There is a link between weight loss and sleep apnea. If you lose weight, then the likelihood is that your neck is going to get, size of your neck is going to get smaller, which will help open your airways up more. It's actually even said, and I read this, that about when you lose weight, your tongue gets smaller. I don't know about that, but I read it, and I guess somehow that was substantiated somewhere. I don't know. But again, it gets back to weight loss.
Yeah.
And number two, if you lose 10 to 15% of your weight, it can cut the number of sleep apnea episodes in half.
Just 10%.
10 to 15%.
10 to 15%.
You can cut the number of episodes in half.
So if you're 250 pounds and you lost 25 pounds, you can cut the number of episodes in half.
You may take your AHI from 30 to 15.
Wow.
Now, that's still a lot, but it's cutting it in half nonetheless. Yeah. So that's the correlation between weight loss. That's the importance with sleep apnea. I gave you 5 of the biggest take-home message from me, the complications from sleep apnea, that if you don't get this treated, you don't get this checked, you're walking around with sleep apnea that's untreated, you're putting yourself in harm's way to have some harm potentially done.
Man, look, this topic, man, is really, it's leaving me in awe because, I guess the revelations about the statistics relative to it, that's enough right there. Yeah. Okay, to make you want to.
1 billion people worldwide estimated with sleep apnea.
1 billion people.
And 80% don't know it. Over 80%.
We have your next topic already. Cookie says knee replacement.
Okay.
Knee replacement. Yeah, we'll talk about that next episode down the line somewhere. This has been fascinating. Listen, we have a couple more minutes, maybe 5 more minutes. If you have a question about sleep apnea or even diabetes, if you're under diabetes treatment, you want to know more about the medication you're taking, or what's new on the market. If you missed the top of the episode, Dr. Mack pretty much said, hey, stay away from the stuff that the pharmacist is not giving you. If there's something on the counter, if it's something you can just walk in and pick up in a pharmacy, do not take it. But the diabetes medications, especially those tied to lowering your A1C and weight loss, you need to make sure they are prescribed. And so we talked about that, and the effects of GLPs and all the things. He also covered sleep apnea, which obviously is a hot topic, and gave us a great demonstration. This show, of course, will be available for playback for the next week. So I suggest, if you know somebody with sleep apnea, somebody who needs to go and check themselves out or whatever, just share a link to this broadcast. We're on YouTube, we're here on Facebook, and have that conversation with them, because it would be a shame for someone to actually lose their life over this sleep condition that obviously can be, I won't say treated as in go away, but it can be managed. Is that a better way to say it, Dr. Matt?
Exactly.
Okay. All right. So you got all kinds of great things. L'Oreal says, how about talking about heart disease among Black women? Okay. Great topic. Dr. Matt, she said, JD said he needs to call his dad. Okay. Right. And then we got Eugene Bellamy watching tonight. Yes, please watch. And thank you, Stephanie Sessions Malone. And we saw Rhonda Sessions in here. Some more Sugar Hill. I told you a lot of Sugar Hill was in the house tonight. She says, good show tonight. And it really was. Beverly Mitchell says thyroid is thyroid health, I guess, is a needed topic. So what I'll do is take a list, I'll develop a list and send it to you.
Okay.
And we can make it happen.
Okay. Sounds good.
Yes.
Doc, man, I really appreciate your knowledge that you're willing to dispense, for our viewers and for me too, especially on that topic. And I'm just surprised based on what you just told us and statistics about that kind of stuff, that you just don't hear about it in advertisement on the TV like you hear about. I know diabetes is prevalent also, but I haven't seen anything about sleep apnea. I could be wrong. It might be in there, but I just haven't.
Well, it's very little stuff, but again, it's a major issue, and it's something that we call a modifiable death risk. You can get in there and you can control this stuff if you get in there and you get treated. Okay. The biggest issue is the mask, and I'm telling you, I know it's a pain in the butt. I know it is, but I'm telling you, if you're talking about the difference between sudden cardiac death, heart failure, atrial fibrillation, Alzheimer's, man, if you're telling me I can take something and it's going to reduce the chances of that happening, hey, sign me up right now. And again, I brought all the different masks so you can see them. There is a mask that will be your mask of choice. You just got to try it. You just got to say, let me put it on, not only the headgear size, but the nasal or the mask size.
Excellent. We're going to say, I'm going to ask one thing. L'Oreal brought it up, and it's a good question. Basically an add-on to what we were talking about as far as like gadgets and things that people tend to sell or try to sell you to deal with the sleep apnea. What about the pillows, the sleep pillows that, kind of, I guess, put your neck in a different position, Doc?
So
do you have any thoughts on those?
If you've got mild sleep apnea, where you don't need a machine, then yeah, sure. Can you use those wedge pillows with the machine? You can. But again, if you've got diagnosed sleep apnea, nothing replaces either one of these surgeries that I named, which may or may not take care of the whole problem. No. I've had patients that have had UPPs and had things like that and still had sleep apnea. So you know, if you've got it and it's saying that, look, when you did the sleep study, you were on this kind of mask at this pressure setting, at this, and all the symptoms went away, then that's what you need. And that's how they determine what machine, what setting you should be on, is all those symptoms with the heart rate going up, the oxygen going down, the leg movements and arm movements and the thrashing. All that stuff goes away at a certain setting, and that's where we know where your machine should be set at. And another thing too, if you've got sleep apnea, don't change these machines yourself. Go to a qualified professional who knows what they're doing, because sometimes you can change. I had a patient change the machine settings, come in to see me, and they were wondering why they were getting worse. Well, they changed the machine from what it should have been on.
Yeah, man.
So it has to be done by somebody
very dangerous.
Who knows what they're doing.
Yeah. JD Spain brought up a good topic as well. You know, it's amazing that there are these treatments and options and things like that. And like he says, but some people just do not have health care, and it could be extremely costly if they don't have something to help with the cost of these machines or whatever. So maybe, you know, we could discuss in a different show or whatever, or if you know some information right now, Doc, on what people can do to if they don't have any health care.
Well, some of these companies that sell these CPAP machines, they can give it to you or let you use it, get it at a reduced price.
Yeah.
Sometimes they may have used machines that, you know, they do refurbish, and they can give it to you at a lower price. Or sell it to you or rent it to you at a lower price. So, you know, again, sometimes it's just talking to those folks and seeing if they'll be willing to do that.
Wow. Well, this has been a fantastic topic, and we just want to thank everyone who's hanging out with us tonight. I mean, Brother Edward from all over the place, from Virginia down to Charleston, over to Columbia, and everything in between. We appreciate everyone for being with us tonight. And again, thank you for dropping in all the topics. We will make a list and send it to Dr. Mack, and time permitting, whenever he wants to come back, we can tackle some of this good stuff. Also, we know that, you know, he's given us great health and medical issues reporting, but if there are other topics that you would like for us to, talk about, bring a special guest on to have a discussion, please let us know. You know, we're still hometown community grassroots. And it is always great when we can bring people on to talk about things and be open and candid. Brother Edward, Mac Jr., I just called you Mac Jr. Dr. Mac blew your mind a little bit earlier. But the bottom line is we want to be able to talk about these topics, and we need to make sure that we're being educated in our community. So thank you so much. And let's see. Oh, there's something else. Yolanda Duke said she hasn't been tested since she lost weight, but received a new machine that I have not used. Should I be retested? That's a good question.
Yes, so it depends on how much you've lost, and if the settings are the same, then they may need to be adjusted. Or if you've got an auto-PAP machine, it may still be in that same range. Again, a lot of doctors, include myself now, if a person tests for, let's say, 10, I may put them on an auto-PAP with a range of 5 to 15. And the machine is smart enough to know when to give less air, less pressure and more pressure. But that's more of an issue if you've got a straight setting. Auto-PAPs usually can adjust for that because the machine knows how much to give. But again, if you've lost a good bit of weight, and depends on what your auto-PAP settings are, I mean, so it may be it may be that you may need to get another study to see if it needs to be changed. Another thing too is that the insurance will cover a new machine every 5 years or sooner if the machine is beyond repair.
Okay.
So it's 5 years.
5 years.
5 years.
Yeah. 5 years for a durable medical equipment.
So there's a question about whether or not it is okay to pass on or pass along a CPAP machine that someone is no longer using. What's the safe way to do that, Doc?
It depends on how old the machine is. It depends on, does it have the appropriate settings that you need for you? And that would be taking it to a company that sells these machines or that services these machines to make sure that they can still find the parts for these machines. It depends on how old the machine is.
Well, this is great. This is great information. So thank you so much. We appreciate everybody. Just like we said, we're on every Tuesday night at 7 p.m. Great topics, great discussions. And Dr. Matt, you know you're welcome anytime. Anytime.
Man,
appreciate that.
Yeah. We gotta make sure that you make yourself available. We got if you want us to take over sometime. I mean, we'll.
I'd be remiss if I didn't say this.
I know what you got.
Brother Edward, please tell your better half I said hello.
I knew you were
I
going
like
to say
you
that
because I love her.
I knew.
Sister April, tell Brother Kendrick that I said hello, my man.
I will. I absolutely will.
Now I can't say I like him better than I like you.
Oh, I'm saying you know better.
I know, but tell my guy I said hello.
I will do just that. Thank you. We appreciate you as well. Yes. So again, everyone, thank you so much for being with us tonight. Y'all had us up late. Look, it's almost 9 o'clock, Brother Edward. But this is good stuff. This is good stuff. When you have a good topic, you can talk all night long. This is fireside chat type stuff. So
go ahead.
I was going to say, we appreciate you, Doc. We really do.
But I want Doc to stick around. We're going to hear the announcement. What the announcement is about.
Oh, yeah. Please, thank you so much. So, yes, we have a couple of announcements. Real quick, I'm going to share the screen and bring one on that that's been brought to us. Priscilla, first of all, thank you so much for always keeping the community in the know. Bring this on. So the city of Conway has a community input survey that's gone out, and they need people to complete this. Now, what I will say about city and county surveys, census surveys, things like that, unfortunately, the Black community doesn't always participate for whatever reason. And then we wonder why we can't get certain things in our neighborhoods, why our questions and problems aren't being answered. They've got to know that we care and that we have a voice. And sometimes these surveys are at least one method of making sure that we get information to them. So there's a community input survey. It's not that long. I'm going to share the link in just a moment, but if you will, please go through and complete this information, and so that the city can use this to I would say assess some things that need to be taken care of in the city of Conway. And be as truthful and open as you can. Let them know what your thoughts are. They're not trying to dig into your business or anything like that. Really, we need to let the city of Conway know what's going on and that we're here too and that we have a voice. So, Brother Errol, let me see if I can find that link real quick. But also, I want to show there's one other thing that is happening that is of vital importance. And it's related to what the NAACP is doing in the community in terms of voting. So the Conway branch of the NAACP, that's branch number 5509, is asking faith leaders and members of the Divine Nine to assist them in getting people out to vote. And the letter states, as we prepare for the upcoming election, they're asking for partnerships and helping increase the voter participation throughout the communities. During this recent primary election, only 20% of registered voters cast a ballot. Our churches, fraternities, and sororities have been long trusted voices in the community. Together, we can educate, encourage, and mobilize voters by sharing accurate information about the importance of voting and what is at stake in the election. So there's a community meeting on Thursday, August the 20th at 11 a.m. at Bethel AME Church. And during that meeting, there will be a discussion of strategies to inform and engage the communities, collaborate on voter education efforts, and identification of ways that the community can work together to increase voter turnout. So they're asking faith leaders and the Divine Nine to come out to this particular meeting Thursday, August 20th at 11 a.m. at Bethel AME Church. And this comes from Carmela Mel Hemingway, who is the current president of the Conway branch of the NAACP. So that was one other thing that I wanted to share with you all as well. And then we also had an announcement from the Myrtle Beach branch, and this comes from the branch president. Where is it? If I can find it. Brother Edward, fill in while I'm looking for this.
Yeah. Regarding I like to go back to that survey. I like to let people know the importance of that survey, because you know, when we call ourselves wanting to be at the table when decisions are being made, these are some of the things that help decisions for the people who are charged to do so. Right, Doc?
That's right.
Yeah. So that survey is, filling out that survey is very, very important, and I certainly hope that our viewers take that very, very seriously, and just take a peek at it and just sign it. To fill it out. And April will have I think she had a link up there, or she will have a link later on.
Now, and I'm going to say this: when you all have information that you want me to share, please try to get it to me before the broadcast, the day of the broadcast, because it's kind of tough to pull this information together, and I'm also producing the show at the same time. And so we appreciate all of the announcements. If you have community announcements, I just want to make sure that we have time and we don't forget to get this information in. Let me see if I can share this image. Because it definitely needs to be shared. So hold on a second. Brother Edward, keep talking.
Yeah. Oh, well, I want to give some accolades to the lady who the source of this information, and that's Miss Priscilla Fuller. She's a huge part of the community. The things that she's involved in, and then she comes back and takes it back to the community, and just full of energy, and wanted to see us progress. Want to see the community progress, and and she seems to have all the skills to do so, and she's utilizing them very well, very well. So again, I see April has the flyer up there.
Yes, I can want to kind of enlarge it a little bit so everybody can see it. So this is the flyer from the branch president of the Myrtle Beach NAACP, and I'll take it down right here. Okay, so rise and roll to the polls. St. Elizabeth Missionary Baptist Church on Saturday, August 22nd, starting at 1 p.m. Come out and join the Myrtle Beach NAACP for voter registration, registration verification, voter education, and a community conversation focused on the issues that matter to local families. And we'll post all of these images that we're receiving tonight so that everybody can, take the time to either scan QR codes or get more information. President Andrew says, looking forward to seeing everyone. And again, the NAACP branches in our local area are working hard to make sure that people are educated about voting. This next election, we can't sleep on it. We can't miss it. We've got to make sure that we understand what's at stake and that we are rolling to the polls, rising and rolling to the polls.
Absolutely.
So you got two opportunities here with the clergy and the Divine Nine to have a conversation in Conway. You've got this community event here on Saturday, August 22nd. It's actually going to be at St. Elizabeth Missionary Baptist Church in Aner, South Carolina.
Yeah,
That's
right.
1 p.m. in Aner, South Carolina. So President Andrews, if you could post that in the chat in case people are actually, kind of looking for that, that would be great. And let's see, have I missed anything in terms of what was sent to me as far as these flyers? I think I have one more, and then we need to make a special announcement and we'll be done concerning our summer jobs and Reading Roots programs. Let's see. Here we go. So this flyer as well came from the Conway branch for the faith leaders and members of the Divine Nine. Your voice, your vote. And again, that's Thursday, August 20th, 11 a.m. at Bethel. Lunch will be served. So if you are a member of clergy or Divine Nine, please make plans to join the Conway branch of the NAACP at Bethel AME Church. It will be greatly appreciated. So Brother Edward, we have officially wrapped our summer program for youth. Yep, summer jobs. And I'm sure Miss McIver is, if she hasn't already wrapped Reading Roots, is in the process of wrapping that up for students as well. We had an amazing summer with the summer job students, and today was
some good news. You've been some good news. Dr. Mac, man, this year is really has some good news about some of our students, man.
Yeah.
Okay. Really good news.
So today was the second of 2 virtual career fairs. Our students had the opportunity to speak to professionals in career fields that they aspire to enter into either at a high school or after college. And so we'd like to thank all of the community partners who participated, and we'll do an official wrap up probably with our next broadcast so that you'll know who all supported and get to hear a little bit more about what the students learned, but also some of the good news that Brother Ed was talking about that we will be able to officially announce. But we just want to thank all of the community partners who supported the youth summer jobs program this year, and also the Reading Roots program. I'm sure Dr. Mack was a part of that, and many others. And we could not have done it without the community support. This year, we had an amazing group of summer job students. They met Denise Chapman, who talked about workplace etiquette, Joseph Wallace, who talked about financial literacy, Dr. Crystal P. Bowman, and Dr. Matt, you might know this young lady, Layla Leah McIver, about college and career readiness. They were able to meet with professionals in fields that they are inspired by. So they met with Michael Allen, who is an architect and the CEO and founder of MOA Architecture out of Greenville, Vincent Myers from Horry Georgetown Tech, who pretty much could talk about any career field and the importance of, community and technical colleges. They spoke with Jasmine McCrae, who is a software engineer, Sherlyn DeWitt, DRS Consulting, CPA. I don't want to miss anybody. They spoke to Tellers Pillard, who is the owner of Flavor Hills out of Raleigh, and he gave back by speaking with some of our students who are interested in owning restaurants. And it was just an amazing time that we had in the past 2 days. Also, there were students who were able to go on site. So we'd like to thank Loris Animal Hospital, the Trestle Bakery, and the Academy of Hope Public Charter School for accepting students to do career exploration visits this year. I had a great time with them. I really did. We are in good hands. Our students, our scholars are extremely bright and capable. And as Jasmine McCrae said today, and we know Jasmine is accomplished. I mean, she's a phenom who, graduated from high school at 16 and college at like 21. She said, the great thing about it is that these students are so far ahead of us because they have access to things that we didn't have access to, and they're using those things. And that's a wonderful thing. So we just want to thank everyone. Yes, Vince, thank you so much. We appreciate you and couldn't have done it without you as well. And we'll do more next week to just kind of showcase some photos and maybe even some videos or whatever. They have their closing program this Saturday August the 15th at Whittemore Park Middle School, the old Whittemore Park on 378. So if you were a summer jobs participant or in the Reading Roots program, please make sure that you're at the old Whittemore Park Middle School, now Rivertown Complex, by 11 a.m. And you'll see Brother Edward, Ms. McIver, and everyone else who helped with this summer program.
It's in the auditorium. In the auditorium.
Yeah, they'll be in the auditorium. Students were in the program not only to receive all of these enriching activities and to get educated about their careers and to, increase their literacy and cultural experiences, but they are receiving stipends for being in this program and a nice little check from a job. So again, we thank everyone who donated, who sponsored the T-shirt, all the things.
All the people who
the village showed up. The village showed up.
Really. I'm just so thankful. I get filled up sometimes. Getting that kind of support, and I'm glad they realize of what the future can look like.
Mm-hmm.
Okay, with those students, and we have a lot to tell you at the closing.
Yes.
So I wish a lot of people could be there. I know there are other conflicting events going on around the city, but at this particular event at 11 o'clock in the morning, we'll try to make it a good time, I guess. Not gonna last long. Not gonna last long. We're just
not gonna last long at all. People can go and enjoy the rest of their Saturday after that.
We're gonna have lunch. We're gonna have lunch.
Oh yeah, lunch will be provided. So if you're interested in the summer jobs or summer reading program for next year, it might be a good idea for you to just come out and listen. But I can tell you, Brother Elwood, we already have at least three, last count, of the students to register for next summer's program already. And they're all going to share the information with their friends. And that's what we want. We need to grow these programs because this is an amazing opportunity to get them prepared before they even go into their career field. So, Dr. Mack, thank you for your contributions. And we will do appropriate thank yous for everybody else. And again, we'd like to thank everyone who joined us tonight. We will see you next Tuesday, 7 p.m. Same time, same back channel.
Same back channel.
Yes, absolutely. So, everyone have a good night.
Thank you so much, Doc. Appreciate you, man.
Problem. Thank you. All right.
All right.
Gotcha.
Thank you for watching the World Community Magazine's Hour of Power Live on Facebook.